Dr. Messner is joining us from the Chicago area where, as I mentioned, he's VP for Strategy and Institutional Advancement at the Illinois College of Optometry. He and I go back a long, long time, introduced by a mutual friend of ours, Sandy Tennant, and I remember, we really bonded over the fact that about probably 7 or 8 years ago, he and I together trained every coach in Chicago public schools on concussions, with Dr. Messner doing the bulk of those trainings. But he gave up every Saturday for a few months. He just cares about this and cares about your health more than just about anybody. So we're thrilled to have him here to share his expertise. So Dr. Messner, thank you for working through these tech difficulties, and I will yield the floor to you, and I'll be back to help facilitate the Q&A.
Thank you, Dr. Nowinski. Chris, it's been such a pleasure to work with you. First of all, can you hear me? So the key points that I'd like to discuss with everyone today is to talk a little bit about the anatomy of the visual system and give you a basic understanding of how the eye relates to the brain. The eye is part of the brain and how it can easily be affected in the setting of concussion. I'm going to talk a little bit about some of the common eye problems, light sensitivity and eye movement disorders. And then from there, I'm going to go into more of a discussion on the rehab and what can be done. The good news is that with these various problems, there are certainly therapeutic options available to individuals with persistent symptoms. Next slide, please. So I think we need to understand, first of all, that concussion is a disorder that largely affects the white matter tracts of the brain and of the visual system. These white matter tracts are termed axons. They move information around from cell to cell. And I think it's critical to understand from the very get-go that a very, very high percentage of axons within the brain are dedicated to vision, visual processing, and the movement of the eyes, the coordinated movement between the two eyes as we look at various objects. Next slide. So what I'm showing you here is a cut through the brain. This is an MRI view of the brain. The front of the head is on the top, the back of the head is on the bottom. But what you can see here are these white areas that represent the white matter tracts of the brain. This is what is damaged with concussion, and it's predominantly these frontal tracts of the brain, the frontal parts of the brain that are most susceptible. And what I want to call your attention to is something called the dorsolateral prefrontal cortex. And this is something, of course, that Dr. Nowinski and his group have been focused on for many, many years as it relates to, this is one of the seats of pathology in the brain as it relates to CTE. But this is also the generator of eye movements, and specifically very precise, quick eye movements that are termed saccades. Next slide. So when we think about the physical symptoms of concussion, of course, some of the major ones are headache, dizziness, problems with balance, but also problems with vision. Next slide. And if we think about the brain and we think about concussion and we get back to the anatomy of the brain, we know that over 50% of the brain is dedicated to vision and visual motor processing. All parts of the brain are involved with concussion. Similarly, all parts of the brain are associated with vision, processing of visual signals, and importantly, the coordination of eye movements. Next slide. So what I'm showing you on this slide are some of the common problems that we encounter as it relates to vision and concussion. And these include light sensitivity or photophobia, and then a variety of what are termed binocular vision disorders. This is the inability of the eyes to team or coordinate eye movements together. And these fall largely into 3 areas: problems with focusing, problems turning the eyes in or convergence insufficiency, and then finally problems with very specific directed eye movements that are called saccades. And I'm going to talk a little bit more about that later. Next slide, please. So photophobia or light sensitivity, this is extraordinarily common in the setting of concussion. And we know that it, to a certain extent, parallels the course of the headaches that many individuals suffer with concussion. And much of the more current research suggests that the photophobia of concussion in many instances may be related to the underlying mechanism of light sensitivity that we associate among individuals who suffer from migraine headaches. And that has spurred a lot of research recently as it relates to, can we filter out certain wavelengths, or can we damp the visual signal so as to eliminate some of these problems with light sensitivity? Next slide, please. So what I'm showing you here is a slide with a very elaborate graph that essentially looks at the visible spectrum of light. But before we get into that, I want to mention that within the retina, first of all, the retina is the lining of nerve tissue that lines, it covers the back of the eye. And from the retina, we have individual nerve bundles that come together to form the optic nerve. Now, there are about 1 million per eye, about 1 million of these nerve fiber bundles in one eye, 1 million of these nerve fiber bundles in the other eye. These form the optic nerve that ultimately go back to the brain, and that's how we see. But also within the retina are these very, very large cells. They're called intrinsically photosensitive retinal ganglion cells. And these have absolutely nothing to do with vision, but they have everything to do with circadian rhythm. Tells us when to get up in the morning, tells us when to go to bed at night. It regulates our internal clock. And we know now that these cells are seem to be the seat of the problem as it relates to light sensitivity in migraine. And given that most headache with concussion is thought to now to be, or much of it is thought to be, a variant of post-traumatic migraine, that these two may play a role from the standpoint of the light sensitivity that many individuals with concussion suffer. And that's where a lot of this activity is going now, is looking for the secret formula, the special sauce, as it relates to light filtering lenses. There's no right answer on this. I will tell you that there is a certain type of light filtering lens called an FL41 lens that we've been using for a wide variety of neuroophthalmic problems. We've been using these with migraine, and we're now beginning to use these among individuals with light sensitivity related to concussion. Now, this is a filter that is ground in, or it's made up as part of the regular glasses prescription. It's meant to be worn both indoors as outdoors, but its prime function is probably more indoors as it relates to eliminating some of this extraneous light that we encounter on a daily basis that may mitigate the light sensitivity and may also play a role with the headache that many individuals with concussion suffer. Next slide. Before I get off this topic of light sensitivity, we also now are screening very, very carefully for irregularities of the cornea or dry eye, as this may also tip off or mitigate the head pain that many individuals suffer, both in the setting of migraine as well as in concussion. And the reason for that is because the cornea, the front of the eye, the front layers to the eye, that clear, that clear first set of layers, is the most highly innervated structure within the human body. And if these nerves are even minimally disrupted by very minor ocular surface disease, such as dry eye, this can worsen or mitigate the headache that is frequently associated with migraine as well as concussion. So we're now taking a very, very careful look at the cornea, and in many instances treating even what may be very, very minimal dry eye and dry eye complaints in the attempt to ward off or head off some of the headaches that are associated with migraine as well as concussion. Next slide. But what I really want to focus on for the rest of this talk are the binocular vision problems that are very, very common in the setting of concussion. And these include problems with focusing, also known as accommodative disorders, problems turning the eye in, or convergence insufficiency, and then problems with very accurate rapid of eye movements, and these are called saccades. Next slide. Now, This slide shows the overall results of a very nice paper that was reported by Dr. Tina Master and colleagues out of the University of Pennsylvania, Children's Hospital of Philadelphia, several years ago, where they looked at roughly 100 individuals, 100 adolescents following concussion, most of these sports-related concussion. And what they found was that 70% of these individuals had some degree of a binocular vision problem, either problems with focusing, problems with turning the eyes in, or problems with very rapid micro eye movements, problems with saccadic dysfunction. And most of these individuals, it wasn't just one, but it was a series of these binocular vision problems that were encountered. Next slide, please. So I want to begin by talking about problems with accommodation. Accommodation, very simply, is the ability of the eyes to focus. Individuals that are concussed, they may have general problems in that they just don't focus as well as they should, or they don't focus as rapidly as they should. Next slide. Now, this is a slide from my colleague, Dr. Valerie Katouf, who heads up the Lewinson Center for Pediatric and Binocular Vision Disorders here at the Illinois Eye Institute. And what it's depicting is a very simple way that we use in the clinic in order to determine how well an individual is focusing. And that is to simply bring a target up close toward the patient's nose and wait for it to become blurry. This essentially becomes the ability of the eye to accommodate or focus on a near target. Now, it's important to remember that as we age, this focusing ability becomes less. And at about the age of 40 or 45, that's where many individuals will report that they're now having problems with seeing well up close. That's normal. That's part of the normal physiologic process of aging. That's called accommodation. Very simple solution in the way of reading glasses. But individuals with concussion, particularly younger individuals, this focusing becomes off kilter. It becomes more difficult to focus much earlier in life. Next slide. So what I'm showing you here is the relative disparity between these problems with focusing in a general population and individuals that have been concussed. And you can see that focusing problems within young individuals occur in roughly 6 to 9% of the general population. But if you look at various concussion studies, these numbers are upwards of 40% or greater. So clearly, problems as it relates to the brain in order to innervate the appropriate musculature of the eye to focus on near objects, very common problem with concussion. Next slide. The next disorder that I'd like to talk about is something called convergence insufficiency. Next slide. Convergence insufficiency, very simply, is the inability to turn the eyes in. If we look at a near target, and you can do this to yourself right now, if you take your finger and you put it a couple of inches in front of your nose and you look at it, there are three things that happen. The eyes turn in, focusing is brought into play, and then the third thing is that the pupils become much smaller. Now, this is all a derivation of what is going on within the brain and a specific part of the brain called the midbrain. But this is commonly affected in the setting of concussion, so that it not only is it more difficult to focus on objects up close, but it becomes that much more difficult to turn the eyes in. Now, under normal circumstances, particularly for younger individuals, if we bring a target up close, they can pretty much follow it and they can pretty much track it right up to the tip of the nose. But if they're concussed, they can't go that far. Usually they can't get beyond about 4 or 5 inches from the tip of their nose. And that, by definition, is something called a convergence insufficiency. Next slide. Now, this is another slide from Dr. Katouf's collection, and what you can see is that she is bringing this target up close to this particular individual. If you look at the left eye, you can see that the closer the target is brought, the left eye begins to kick out. So the individual that's doing the test sees the eye deviate outward. But in addition to that, that's where individuals will typically say that instead of seeing one object, I see two. And for most individuals, they can come into 4 inches or closer to the nose. If they're concussed and they have convergence insufficiency, it is significantly receded. Next slide. So that's the science. Those are the clinical manifestations of convergence insufficiency. You may say to yourself, well, what does this really mean in the real world? Well, it's eye strain. And it's eye strain that people experience whenever they're looking up close. Now, I got to tell you that that has changed dramatically within the past 10 years or so, particularly as we become more tuned into looking at computers, looking at other screen-like devices, in that there are many more individuals that are now complaining of sustained problems with near work. But concussion can certainly make this worse. Many years ago, a very famous neuro-ophthalmologist, Dr. J. Lawton Smith, called this the sleepy student syndrome, meaning that individuals that had difficulties turning their eyes in, if they were trying to read a book, if they were trying to study, they would become drowsy and they would fall asleep. Well, when that's still true, but as we're looking at computers now, we're usually not falling asleep in front of our computers, but what we may be doing and what individuals with concussion typically are noticing is that, boy, I'm just noticing an awful lot of eye strain. And that actually sometimes if I cover one eye, it makes it easier. These are common symptoms of convergence insufficiency. Next slide. And here again, looking at the data of a number of studies comparing the prevalence of convergence insufficiency within a general population as compared to individuals with concussion, you can see that in younger individuals, about 4 to 6% of the population has some evidence of a convergence insufficiency. But here again, if you look at individuals that are concussed, 40% or higher have problems turning their eyes in. Next slide. The last type of binocular vision problem that I want to talk to you about are problems with very precise rapid eye movements called saccades. Next slide. Now, saccades are particularly interesting in the setting of concussion because in order for an individual to go from object to object very precisely, very accurately, it requires many areas of the brain to be functioning, not just properly, but to be functioning in coordination with other higher brain centers, and then feed down to the individual muscles. We call these extraocular muscles that are responsible for the eyes moving left, right, up, and down. Next slide. And the reason that we're particularly intrigued with problems of saccades in the setting of concussion is that the brain really needs to be functioning properly in order to move quickly from object to object. So these saccades, these fast eye movements, they need to be fast, they need to be accurate, and the brain must be discharging at very high rates. So there's a lot of stuff that needs to be going on between the brain and the eyes. And from that standpoint, it stands to reason that these micro eye movements, these saccadic eye movements, are prone to dysfunction with concussion. And indeed, a number of years ago, there was a study that was reported in the journal Brain that showed among individuals with post-concussion syndrome, one of the most common problems and one of the most significant indicators of other symptoms related to post-concussion syndrome was difficulty with saccades. Next slide. So this got us thinking a number of years ago at using abnormal saccades as a method to screen for concussion. And that's where many of you have heard about the King-Devick test. And that is really the origin of the King-Devick test. It's a test of rapid number naming, where individuals are going through a series of cards or screens now on a computer, and they're asked to read from left to right a series of numbers as quickly as they can. And as they go from card to card or screen to screen, it becomes progressively a bit more difficult in order to perform this task. But for most individuals to do this test correctly, it takes around 35 to 45 seconds roughly. For individuals that are concussed, these micro eye movements are disrupted, and it takes significantly longer to do this test of rapid number naming. Next slide. So back in 2011, we reported on abnormal saccades and the identification of abnormal saccades using the King-Devick test among individuals who were recently concussed as a result of both mixed martial art bouts as well as boxers. And what we found is that it took these individuals significantly longer to perform this rather simple test of rapid number naming. Next slide. And what I'm showing you here graphically is this disparity between individuals, both boxers as well as MMA fighters, from our original study, showing that it takes longer to do this simple test of rapid number naming among individuals that have been concussed, and particularly among individuals that have been concussed when associated with loss of consciousness. Next slide. So the slide that I'm showing you here is a meta-analysis that was published several years ago, looking at a compilation of many, many studies using the King-Devick test as it relates to the ability to diagnose concussion as a sideline screening tool. And essentially, looking at the studies that have been done, this single test is very sensitive and specific for identifying concussion. But the bottom line is that we don't expect individuals to become worse when a baseline has been performed. So athletes are screened on a regular basis to get a baseline, and then if there is suspicion of concussion, they are then immediately tested on the sideline. And what we expect to see, if anything, is no worsening of their baseline King-Devick scores. If they are getting worse, that is a very significant indicator that the individual has probably been concussed, and they should be removed, not allowed to return to play until being cleared by the appropriate healthcare personnel. Next slide. So up until this point, I've been going over with you some of the very common problems that we see as it relates to vision, specifically light sensitivity, how this may be tied into headaches, and also some of the very, very common binocular vision problems. Problems with focusing, problems with turning the eyes in, problems with rapid eye movements. So the question then becomes, what do you do? Well, it depends. Most of the time, individuals will improve within a couple of weeks following concussion. So going back to what Dr. Nowinski and others within the Concussion Legacy Foundation have been recommending for years, and that is that the first treatment for individuals largely who have been concussed is to rest from both a physical standpoint as well as resting from a cognitive standpoint. But if these symptoms, and particularly as it relates to vision problems, if they persist, then certainly it's a matter of intervening, and intervening with some form of rehabilitative therapy. Now, what we think is probably best now is that we begin to segregate individuals with concussion as being pre-adolescent or pre-adolescent versus adolescent or adults. If they're adults or they're adolescents, generally if they have persistent visual symptoms such as those that I've already described for you, that if it's been going on for 2 weeks or more, that these individuals should be evaluated, and in most instances, they can be prescribed a specifically regimen of what is generally termed vision therapy in order to improve these symptoms. Now, oftentimes, it's not just a matter of treating the visual system, but it's also a matter of combining the vision therapy with forms of vestibular therapy as well as cognitive rehab. But at least for adults or adolescents, we generally like to give them about 2 weeks or more to get better, about 2 weeks to get better. Now, kids are a little bit different. If they're preteen, The general recommendation that we ascribe to is to give them more like 4 weeks to a month. If they're not getting better after four to 5 weeks, then it's probably time to intervene. But the good news is that for those individuals with persistent vision problems, as it relates to eye strain, and particularly eye strain related to computer work, as it relates to eye strain, looking at reading other forms of near point tasks, vision therapy can be very, very effective for this. Next slide. So just in summary, hopefully I've been able to impress upon you the significance as it relates to vision and concussion, that the eye is part of the brain. We think of it as being literally the front door of the brain, both structurally as well as functionally. So it makes a lot of sense scientifically, anatomically, to think of it in the context of that if the brain is jostled in the setting of concussion, it's very, very common to have these problems with vision. In addition to that, we spent a fair amount of time rather talking about common problems of vision, both light sensitivity as well as eye movement disorders. And then finally, what can be done for individuals with persistent symptoms as it relates to vision rehab. So that's the extent of my presentation. Dr. Nowinski, I'm happy to take any questions.
Thank you, Dr. Messner. That was terrific. A virtual round of applause, I'm sure, from all of our panelists. And I appreciate all the comments that have been coming in. I feel great sympathy for how much some people are struggling with symptoms right now. And I hope what Dr. Messner said is helpful with the education provided, but I also hope that we can be helpful to you individually through our helpline. And so, Dr. Messner, we got a bunch of questions. I'm going to start to provide some, and then the staff is curating stuff that's come in recently. So now, and you guys feel free to text me stuff so I know what you'd like me to answer. I did see one question regarding double vision. Do you want to revisit that in terms of the cause of double vision after concussion and what therapies help that recover?
Sure. Certainly, when these people are seeing me immediately after concussion, my job is to do a neuro-ophthalmologic evaluation, essentially to determine what is the severity as it relates to what's going on within the eye. Or there are other signs that they may be bleeding into their brain, that there's elevated intracranial pressure. But one of the first things is a cranial neuropathy. And there are 3 cranial nerves, 3, 4, and 6, that can be damaged in the setting of traumatic brain injury. Of those 3, perhaps the most common is the 6th cranial nerve. And that is the nerve that is responsible for turning the eyes out, right eye to the right, left eye to the left. So these are people that will typically complain of problems with double vision as it relates to the objects being misaligned side by side. So that's the first thing, is to determine, are the cranial nerves working properly? I can tell you that the vast majority of the time, the answer is yes. And that it then boils down to what is more of a binocular vision problem that in many instances may be more related to a convergence insufficiency, such as when we ask an individual to look at a target as we're pulling it up to the nose, that instead of being able to pull it very close to the nose, the eyes splay apart and the individual notices double vision. That's not nearly as serious as the 6th nerve palsy. That's fairly common. That's something that's responsive to vision therapy.
That's good to hear. And again, we won't get to every question. So the most important thing we'd say is, the advice for everyone with PCS is continue to rehab, continue to find, if you're not getting help you need now, find new doctors, try new therapies, because something will eventually work. And doctors don't always have the perfect way to assess what will work. So Dr. Messner, just so I can get it in now, if they're in the Chicago area, how do they book with you or your experts?
Sure. I see patients through the Illinois Eye Institute, which is a division of the Illinois College of Optometry. Our concussion center is housed within the Lewinson Center for Pediatrics and Binocular Vision Disorder. The chief of that service is Dr. Valerie Katouk. She is absolutely terrific, and I send all of my concussion patients to see her, and she works her magic with them. The website is illinoiseyeinstitute.org. You can go there, you can click on the tab for pediatric and binocular vision disorders. It'll take you to the Lewinson Center. Their direct line is 312-949-7280.
Thank you. And for everybody else, if you can't get to someone to there, again, concussionfoundation.org/helpline. We will find you somebody in your area that can help you. So first question from I'm going to ask here: any advice for a PCS student who, after over a year of vision therapy and experiencing good progress, switches to online learning and suffers a backslide? Everything's on screens now. Should only work for 30 minutes and must take a break and gets behind. I have to imagine that's happening to a lot of folks. Any thoughts?
Yeah, that's a great question. I guess to begin is that it's encouraging that there was a good response to an initial foray of rehabilitation. There are individuals that have something of a regression back to the mean. In many instances, there may be maintenance therapy that is prescribed and recommended after they go through the active phase of therapy. But I have to tell you, getting back to this whole issue of screen issues and eye strain looking at computers, it's very, very difficult now really to separate this out as to what may be related to concussion and what is simply an inherent problem as it relates to dealing with all of this screen use. Our eyes, our brains, very simply, were not designed for this. So we need to adapt to it. We need to do things. I'll tell you that in many, many instances, very, very small or what would be thought to be subclinical vision problems or vision correction issues that we used to simply dismiss as saying, you really don't need a pair of glasses for this, particularly younger individuals that have farsightedness. That now we're rethinking that particularly with a lot of near work, that sometimes that's what it takes, is simply correcting their uncorrected refractive error. And that if they have some farsightedness that's uncorrected, oftentimes that's a pretty good place to start.
All right. This is from Risa. Is 3 years out from a concussion and struggling to read for longer than 30 minutes without getting nausea, tingling across top of the head, headache, and an inability to comprehend the material. She's tried colored lenses, prism glasses, and vision therapy, along with different print and screen filters. What else can she do to improve her reading tolerance? We're deep in the list.
Yeah, that's a great question. Of course, what you're certainly describing are many of the vision problems with post-concussion syndrome. And Chris, you yourself, of course, have just been really a bright light as it relates to having individuals identify with those symptoms. But I guess getting back to the question, first of all, I think it depends upon what is the age of the individual, and I get back to before. This issue of focusing problems becoming more manifest with time. When we're young, we have a very vibrant, a very robust focusing system. As we get older, we lose that ability to focus. And particularly for most individuals, when you begin to reach about the age of 40, 45, that's where it becomes significant. And that's where bifocals, reading glasses seem to do a world of good. For those individuals that have a little bit of farsightedness, or sometimes individuals that have a lot of farsightedness, where they've been able to carry on quite well, for many, many years, they may run into these nearly problems sooner than the usual age of the presbyopic patient. Now, you throw concussion into the mix, you throw other accommodative problems into the mix, you're further compounding the problem, not even to mention all the issues as it relates to eye strain with computers, so on and so forth. So I think that the best way of, it sounds to me as though for an individual that's already been through the gamut, it would be, probably your best option as opposed to just shotgunning something is, that's what the academic medical centers are there for. And to a large extent, that's what institutions like ours do on a regular basis. Is we handle those individuals that simply have not responded to standard therapy that may be offered in a general outpatient setting. So, I'm certainly happy to share with you some of the additional resources that I have, some recommendations, posting them to the helpline, because I think that, in addition to the information that I've given, probably another thorough evaluation to determine what really is the problem, and then figuring it out from there.
Yeah, and as much as you may not want to get another evaluation, they always help if you with the right people.
Yeah, and just tag on to that, we understand that there are only so many academic medical centers within the country. But what we do, and what I'm sure a lot of others do, is that we'll do the consults, we'll evaluate individuals. They'll develop a management or a treatment plan so that the individual can take it back to them, so that their provider, their eye doctor, their local provider can take over from there.
Yeah, and I've seen a few comments sort of come up on the side in terms of, am I too far away from my concussion so that I'll never get better? And I'll just answer that for you, because I know I've already heard you say it many times. You're never too late to start rehab, right? You will respond. So don't just, people who say I've been out, it's been a year, 2 years, 3 years. We know people have responded for much, much more time. It just takes getting the right help. So don't worry about that. Just become an active patient. All right, Amanda asked, I guess this is that question. That's why I was thinking of it. I saw it somewhere else too. Is it ever too late? It's been 3 years since I started vision therapy. But only started last year for convergence insufficiency. I'm 50 and not much improvement yet. So that's a little more specific of that question. They've been starting it. They haven't seen a lot of improvement. Does that mean they're doing the wrong thing, or does that mean it just takes more time? Your guess.
I think, sometimes it does take more time. Again, I think it really depends upon exactly what is the problem. With convergence insufficiency, whether it's due to concussion or anything else, fortunately, that's one of the binocular vision problems for where there are mountains of evidence in clinical trials, well established within the scientific literature, that it essentially is fairly prescriptive. So, I would say that not knowing anything more, to certainly continue on that course. But if it's not getting better, perhaps getting another opinion would be wise.
Yeah, good advice. Lauren asked, is it typical for photophobia to be the last symptom to resolve?
Yeah, that's a great question. It can be, and specifically as it relates to the connection to the photosensitivity related to migraine. As I indicated before, much of what we're seeing now in the setting of chronic daily headaches with concussion is post-traumatic migraine. And a very significant part of post-traumatic migraine is the chronic constant photophobia. This doesn't mean that people should be walking around wearing sunglasses all the time, but there are special lens filters or tinted lenses. I mentioned to you earlier the FL41 lenses that we use for many of these individuals. In addition to that, oftentimes it's rather, their environmental tasks. It's trying to eliminate the glare that's within your, within your daily environment. But I would say the other big part of that is to, particularly if tied into headache, be evaluated by a headache specialist. Be evaluated by someone to determine, is this part of a migraine syndrome?
Yeah. And I'll just tell Lauren, I still, I still have photophobia issues, and I'm 17 years later. I'm happy with, like, screens aren't an issue and things like that, but I don't go outside without sunglasses on a sunny day. And if it's just sunglasses that I need to be all right, I just make sure they're handy. But I wish you the best with that. Essentially, you mentioned FL41. The next question was from Hannah about, do you have any trusted sources for FL41 glasses?
Yeah. I have to get back to you on that. I can tell you that, as it relates to concussion, there is sketchy data that's out there. I will admit that to you. As it relates to migraine, as it relates to something that I've been recommending these lenses for a number of years, and that's with a condition called essential blepharospasm. Essential blepharospasm is where individuals just have this rapid closure, involuntary closure of the upper and lower eyelids, both eyes, that's completely involuntary. And there's really not much that they can do about it. It's something that sometimes is responsive to Botox, but as we teach our residents and students on a regular basis, one of the easiest diagnostic criteria is to shine bright lights in their eyes. The individual with blepharospasm will really ramp up those rhythmic involuntary episodes of eye closure. So from that standpoint, light filtering lenses we found to be quite helpful, not necessarily in curing individuals of their blepharospasm, but certainly as it relates to maybe improving and as adjuvant therapy related to other measures. With blepharospasm, that would be Botox. The problem specifically as it gets to concussion is that it's still a little too early to tell. A lot of what we know, we're basing upon the data, the scientific data, as it relates to treatment with migraine. So essentially, that's where we're coming from.
Right, that gap exists, but you and your team are doing great research to try to close it. From Sean, how do you fix depth perception issues?
Yeah, that's a good question. It really depends on what's causing the problem with depth perception. And oftentimes that's related to two of the problems that I've discussed with you before. The inability of the eyes to focus or focus in a symmetric fashion, and the inability of the eyes to converge or turn in and look at a near target. So, first thing is always a comprehensive eye examination to rule out all of the other bad things that could be problematic. But getting back to these binocular vision problems, that's where I certainly rely on the vision rehab specialists to pretty much take over from there. They do a very sophisticated evaluation, specifically looking for these problems and then determining what's the best therapy.
Patrick asks, is it normal to have a headache for several days after vision therapy, or is that not a good sign?
Yeah. I think that, there are a couple of ways of looking at that. I would flip it around and say that it's not a bad sign in that particular is you're now taxing the visual system to do more, and it's something that it's not used to doing. There's going to be some discomfort that goes along with that. I mean, I guess we can think about it as it relates to other physical activities. If we're starting a new workout program, a new exercise program, there are going to be those aches and pains. Now, the one thing that I want to make absolutely clear is that when we talk about vision rehabilitative therapy, from the standpoint of binocular vision, they're not eye exercises. It's really more a matter of assisting the brain in, for all practical purposes, reprogramming itself. But in that process, yeah, there will be eye strain, and particularly for individuals that are just beginning to learn to use both eyes together, that eye strain may be more significant. So oftentimes things will get worse before they get better.
It's a simpler language question. Somebody asked, what can we go over which kinds of eye doctors people should be seeing and what they do?
Yeah, I think the first step is to have a comprehensive eye examination by an optometrist or an ophthalmologist. That's really where it begins. And I go back to the dictum that that's been recited to me by Dr. Katoof and others in our department, and that is that oftentimes the first step is to correct their uncorrected refractive error. And I go back to this issue of concussion. The brain is knocked off axis, and so too has the visual system been knocked off axis. You then couple that, you complicate it with much more screen activity and other things that we're doing more of now. So that oftentimes it's simply a matter of correcting that uncorrected refractive error and see how that helps. If that's all that's required, great. If not, then from there, it's more a matter of delving into these binocular vision problems. So getting back to the initial question, comprehensive eye examination, drops in the eyes, the whole thing, by an optometrist or ophthalmologist in correction of their uncorrected refractive error, that's probably a pretty good place to start.
Yeah, move up from there. All right, Lori asked, this one I haven't seen. My daughter suffered a concussion in October. It also tore her retina. She had laser surgery to repair it, but is still seeing floaters. Is that normal? How long after the concussion should she continue to see floaters?
Yeah, well, that's a great question, because with blunt trauma, and that gets back, I think, to my original statement, is that step one following any trauma in and around the eye is a comprehensive eye examination with a comprehensive retinal examination where you're putting the drops in the eyes, you're dilating the pupils, and you're looking at the retina with great scrutiny. So getting back to this instance of a retinal tear that it sounds like was successfully treated with laser photocoagulation, that's great. Typically, when a tear has been identified before it's had a chance to progress to a retinal detachment, if it's been treated with either a laser technique or a freezing technique, it's one treatment, one and done, and you're usually pretty good from that standpoint forward. Now, as it relates to either the injury or the procedure, it's then pretty common to have other changes that occur within the eye. As it relates to the jelly-like material in the middle of the eye that's called vitreous, it begins to liquefy, it begins to separate from the surface of the retina. And that's what most individuals notice as it relates to floaters. The problem is, without doing a retinal examination, we really don't know if it's something simple as opposed to your vitreous detachment, relatively normal floaters per se, or is this a new tear and these floaters are related to new bleeding into the eye, or into the vitreous rather. So I think step number one, if this has not already been done, is to ensure that there's not a new tear and that there's not more recent bleeding into the vitreous. Now, assuming that that's not the case, it becomes, what do you do about these persistent floaters? And there's been a lot of research and study as of late as it relates to what, if anything, needs to be done. If you Google floaters and therapy, there's a lot that's being reported now in the context of laser treatment or floaters. I will tell you that in our retina service, our retina surgeons tend not to look at this tend not to be big fans of this. That yes, it can work, but there are inherent complications with these laser procedures, such as the pressure going up inside the eye, such as cataracts developing, such as new bleeds occurring within the eye. So I can just speak from the standpoint of our retina surgeons don't tend to be big fans. I think that overwhelmingly the bigger issue is that if these are floaters that are of a fairly innocuous nature, meaning a posterior vitreous detachment, more often than not, simply reassurance to the patient that, yep, I hear you, it's a problem, I notice these as well. As we get older, we're all going to notice more in the way of floaters. But as long as it's not related to bleeding into the eye, a new retinal tear, more often than not, we think that probably the best thing to do is reassurance and observation.
Yeah, that's good advice. You are a font of wisdom here. We could probably do this all night, but we are coming up on the hour. And so I think I've been chatting with the staff. There's so many questions, and you're so good at answering questions. We've been doing a 20 question series with Dr. Cantu, and I think we want to bring you back for a just Q&A with Dr. Messner in a few months. So we're going to hold on to all these questions, and we're going to let everybody who's been watching know that if you will agree to it, we would love to grab another hour in the future to go through all these.
Sure, it would be my pleasure.
You're the best. Okay, so with that, I think we will give you a big round of applause right like this and virtually, and I'd love to see all the thanks messages that we'll send to Dr. Messner from the chat if you enjoyed it. I've seen a lot of great thank yous, and they're flying in now. You guys are a very appreciative group, and we appreciate your thank yous. I want to thank the staff for putting this together and for figuring out our technical difficulties. We'll have to figure out what happened there, but we went through it just fine. So I've seen about 100 thank yous flying through here, Len. They love you. All right, so I'm going to wrap up here. So we'll say goodbye to you, and I will give a few more sentences before we say goodbye with some other resources. So thank you again, Dr. Messner.
Thank you.
All right, Brandon's putting up a slide. There he is. Okay, so be sure to sign up for the final webinar in our summer series. It's next Wednesday, 4 p.m. Eastern. Dr. Tamara Wexler from NYU will present on what patients and families need to know about neuroendocrine dysfunction after concussion. This is coming up a lot. Thanks to Tara Rockefeller for connecting us to Dr. Wexler, who we've already been referring patients to, and finding that some people's long-term symptoms do have something to do with neuroendocrine dysfunction, and they can get better. But it's not something that we often talk about with post-concussion syndrome, and it's not always evaluated at every clinical visit. So the link to the register for that webinar is in the chat. Again, we want you to know that we are here for you and your family. If we weren't able to get your question today, if you're looking for help for you or a loved one, I saw some of the chats there with ex-athletes who've had too many concussions and aren't getting the answers. Please reach out to the CLF helpline, concussionfoundation.org/helpline. I mention the athletes just because those stories always resonate with me as an ex-football player, but obviously we're here for everybody. I don't care what the cause of that hit to the head was. We want to help you out. If you found this helpful, want to pay it forward. A donation of any amount will help us out to create more resources for this community, continue to provide these webinars. You can find a donate link in the chat. We always appreciate that we get a bunch of donations after these, so you guys are very generous. So the final slide, thank you so much for joining us. Please let us know what you thought of today's webinar in the poll that Tyler is launching right now, and we look forward to seeing you next week. Stay well.